Welcome to the Deep Dive, the show where we cut through the noise, sift through the sources, and really pull out those key nuggets of knowledge for you. Today we're diving into something that affects everyone, but often feels, a bit of a black box.
Oh.
Your gastrointestinal system. And what happens when things go a little sideways? We've got a stack of research here, covers everything from like subtle body signals to complex diseases and the treatments that follow.
It's a truly vast system, isn't it? And vital. Our mission today really is to give you a clear, kind of practical roadmap. How are GI issues identified? What do diagnoses actually mean? And how are they managed?
Right.
We'll be focusing on those key insights that can help you understand your own body better, or maybe just be a more informed advocate for yourself or others.
Exactly. Think of this as your essential guide to the gut, top to bottom. Hopefully full of those aha moments. Okay, let's unpack this.
Let's do it.
So before we jump into specific conditions, maybe let's start right at the beginning. How do healthcare pros even begin to figure out what's going on inside your GI system? It kicks off with assessment, right?
That's right. And what's really fascinating is just how much groundwork goes into it. It's far more than just asking what hurts. It really starts, best practice, with a thorough patient history.
A patient history? Okay, that sounds like more than just symptoms. What kind of things are they asking?
Oh, the scoop is quite broad. They're looking for clues in your, daily life, eating habits, elimination patterns, that sort of thing. But it goes deeper. Your age, gender, cultural background, any previous GI disorders or abdominal surgeries, and this is key. Every single medication you're taking.
Everything, like even vitamins.
Everything. Prescriptions, over-the-counter stuff, herbs, supplements, even things like past or current tobacco use, or if you've traveled recently, they're all potential puzzle pieces.
Wow, that's incredibly broad. And I guess nutrition must play a huge role here too.
Absolutely huge. So a detailed nutrition history digs into special diets, food allergies, maybe changes in eating habits because you haven't felt well, and specific symptoms like anorexia, loss of appetite, or dysphagia, that's difficulty swallowing, or dyspepsia, which is just indigestion.
Right.
Even things like unintentional weight loss, alcohol, caffeine intake, and interestingly, socioeconomic status are relevant factors. They all impact diet and access.
And family history, I imagine that can unlock some clues.
Oh, definitely. Family history of GI disorders is crucial. For example, there's a condition, familial adenomatous polyposis, FAP.
Okay.
It's inherited, significantly boosts colon cancer risk. It really makes you wonder, how much of our gut health is basically written in our genes.
A really important question. So once they have all that history, what's next?
Yeah.
Physical assessment.
Yep. Then comes the physical assessment, looking at nutritional status overall, checking the mouth, and then the abdomen. And there's a really specific order for the abdomen exam.
Oh, really? What's the order?
It's inspection first, just looking, then auscultation, listening with a stethoscope, then percussion tapping, and finally palpation, gentle touching.
Okay. Why that specific order? Look, listen, tap, feel.
It's preferred because you want to listen to the bowel sounds before you start poking around, which could, artificially increase intestinal activity and noise. You want the baseline first.
Makes sense. So what are they looking for during inspection? Just looking at the belly?
Well, yeah, but specifically observing the skin, the shape, the symmetry of the abdomen, the umbilicus, the belly button. There's even something called Cullen's sign, a bruising pattern that could suggest internal bleeding.
Wow.
And abdominal movements. Then for auscultation with the stethoscope, they listen for bowel sounds. Normally, they're like high-pitched, irregular gurgles, maybe every 5 to 15 seconds.
Okay.
They note if sounds are normal, hypoactive, quieter, or hyperactive, more active. They also listen for borborygmus, that's loud tummy rumbling, or brutes, which are whooshing sounds indicating potential blood flow issues.
And percussion, the tapping. What do they tell them?
Percussion helps estimate the size of solid organs, like the liver or spleen. It can also help detect masses, fluid, or air. The sound changes might be tympanic, like a drum over air, or dull over a solid organ or fluid.
So they can tell if the liver or spleen is enlarged.
Exactly. Hepatomegaly or splenomegaly. Then light palpation, which nurses often do, is just gently pressing down, maybe half an inch to an inch, feeling for tenderness, guarding, or rigidity. Deeper palpation is usually for physicians or advanced practice nurses.
Got it. So it's very physical, but you mentioned psychosocial earlier. That seems really important too.
Absolutely crucial. The psychosocial assessment looks at how the GI problem is affecting the patient's whole life, their lifestyle. And we have to remember these issues can be incredibly personal, sometimes embarrassing.
Yeah, I can imagine.
Patients might feel a lot of emotional stress, like with IBS, or even go through grief with a serious diagnosis like cancer. You might see depression, anger, denial. It really brings up a key question. How can we best support people navigating these deeply personal health challenges? It's more than just the physical symptoms.
Absolutely. So after history and physical, we get to diagnostics, lab tests, and imaging.
Exactly. Lab tests involve serum blood urine and stool tests. Common blood labs look at liver enzymes, albumin, pancreas enzymes like amylacylapase, ammonia levels, bilirubin, a CBC, electrolytes, clotting factors.
A lot of info there.
And stool tests are vital. Fecal occult blood tests, fecal immunochemical tests, stool DNA tests. These are important for cancer screening guidelines. They also look for infections, ovas and parasites, fecal fats for malabsorption issues, and bacteria like C. diff.
Okay.
And then imaging, x-rays, CT scans, MRIs, they're crucial for seeing structural or functional problems.
Sure.
A key part for nurses here is patient education. How to prep, explaining the procedure, what happens after.
Right, managing expectations.
Yeah.
Okay, so that's the assessment foundation. Let's dive into some specific conditions, starting at the top.
Right.
The mouth. Oral cancer might not be the first thing people think of with GI health.
That's true. And while we often associate it with older people over 40, say, there's actually a concerning increase in younger individuals recently. So it's really important for everyone to be aware.
Okay, so what are the biggest risk factors for oral cancer?
Well, increasing age is one, definitely. Sun exposure, especially for lip cancer. Tobacco use any kind. Heavy alcohol consumption. Poor nutrition and poor oral hygiene.
So for early recognition, what should people actually look for? What are the signs?
Most oral cancers, maybe 90%, are squamous cell carcinomas. They start on the surface lining. So look for reddish, raised erosions that seem suspicious, or any lesion or sore that just doesn't heal within 2 weeks.
2 weeks, okay.
Or a thickening of the cheek. They often appear on the lips, tongue, inside the cheeks, back of the throat. The highest risk, no question, is frequent alcohol and tobacco use together. There's also basal cell carcinoma, mainly on the lips. It often starts as a small, painless scab, then becomes an ulcer with a sort of raised, pearly border. It doesn't usually spread far, but it can be aggressive locally on the face. Excessive sunlight is the big risk factor there.
Okay. Beyond those specific lesions, are there other general signs someone should be aware of?
Yeah, other signs can include a persistent, maybe painless sore or mass, difficulty speaking clearly, any unexplained bleeding in the mouth, trouble chewing or swallowing, enlarged lymph nodes in the neck, even thick or strange saliva. Assessment involves asking about hygiene, dentures, bleeding, appetite changes, and a very careful look inside the mouth.
And diagnosis and treatment, how does that usually proceed?
Well, the exam is key, checking the mouth and neck nodes, but the definitive diagnosis always comes from a biopsy. If it's cancer, CT and MRI scans check for metastasis or spread. Treatment often involves surgery. That can range from removing small lesions, outpatient, maybe just local anesthesia, to really extensive excisions for more advanced stages, which unfortunately can result in significant loss of function or disfigurement.
That sounds incredibly tough. What kind of extensive surgeries are we talking about?
Things like a glossectomy removing part, or all of the tongue, mandibulectomy removing the jawbone, or even something called a commando procedure, which is a combination of neck dissection removing the jawbone and throat resection.
Wow.
A neck dissection itself, removing lymph nodes and sometimes muscle or nerves, can lead to things like shoulder drop because the trapezius muscle atrophies. That causes visible changes.
That's a lot to deal with, physically and emotionally. What about other treatments? Or the care before and after these big surgeries?
Right. Beyond surgery, radiation and chemotherapy are common. Radiation might be used before surgery to shrink the tumor. Chemo can also shrink it and make cells more sensitive to radiation. There are also newer targeted drugs that block growth factors that these tumor cells often rely on. Nursing care is huge, focusing on airway management, medications, specific, careful oral hygiene. Pre-op care involves assessing physical and psychological state, lots of education, general prep. Post-op, the priorities are airway, communication, protecting the surgical site, keeping the head elevated to reduce swelling, pain management, often strong meds like morphine and nutrition. That might start with NPO, nothing by mouth, maybe IV nutrition or a feeding tube, then slowly progressing to thickened liquids.
Okay.
And discharge planning is key, managing dry mouth, fatigue, maybe tracheostomy care if needed, taste changes, ongoing oral hygiene, skin care from radiation. It's comprehensive.
Definitely sounds like it. Okay, let's move down a bit to a really common one. GERD. Everyone knows heartburn, but what exactly is gastroesophageal reflux disease?
So GERD is essentially when stomach contents acid, mostly reflux, or flow back up into the esophagus repeatedly. This causes irritation, inflammation.
Mhm.
It's actually the most common upper GI disorder out there.
What causes it typically, and what are the classic signs beyond just that burning feeling?
It's primarily caused by a relaxation or weakness of that valve between the esophagus and stomach, the lower esophageal sphincter, or LES.
Okay.
Things that can trigger that relaxation include overeating, smoking, alcohol, certain foods, fatty, spicy ones are common culprits, or even just having an NG tube in place. The signs are numerous: dyspepsia, indigestion, regurgitation, feeling stuff come back up, coughing, hypersalivation, too much saliva, dysphagia, trouble swallowing, epigastric pain, upper middle abdomen, adynophagia, painful swallowing, belching, flatulence and nausea, pyrosis, that classic heartburn, globus, lump in throat sensation, pharyngitis, sore throat, and even dental cavities from the acid.
It's quite a list. So how is GERD diagnosed and treated then?
Diagnosis often involves pH monitoring, checking the acid level in the esophagus over time. An EGD, that scope test, lets them look inside, and esophageal manometry measures the muscle contractions. Treatment is multi-pronged. Lifestyle changes are first line. Avoiding trigger foods and drinks, not wearing tight clothes, eating smaller meals, maybe 4 to 6 a day, avoiding fatty foods, or crucial, not eating or drinking for 2-3 hours before lying down.
Okay, that makes sense.
Maintaining a healthy weight helps, and elevating the head of the bed, maybe 6-12 inches on blocks, is often recommended. Medications include antacids for quick relief, H2 blockers like famotidine, PPIs, proton pump inhibitors like aripiprazole, which are very effective at reducing acid, and sometimes prokinetic drugs to help stomach emptying.
And if that doesn't work?
For more persistent cases, there are endoscopic therapies like the Stretta procedure, or even surgery like the laparoscopic Nissen fundoplication, where they wrap part of the stomach around the esophagus to tighten that valve.
Okay, and speaking of GERD, a hiatal hernia sounds kind of related. What is that?
It is often related, yeah. A hiatal hernia happens when the opening in the diaphragm, that muscle separating your chest and abdomen where the esophagus passes through, gets enlarged. Then part of the upper stomach can actually push up into the lower chest area.
Oh, okay.
There are two main types: a sliding hernia, which is more common, where the stomach slides up and down, and a rolling or paraesophageal hernia, where part of the stomach rolls up beside the esophagus.
And the signs?
Yeah.
Are they similar to GERD symptoms?
Yes, a lot of overlap. Heartburn, regurgitation, dysphagia, belching, feeling full, maybe chest pain, even a feeling of suffocation sometimes. A key thing is that lying flat often makes the symptoms worse.
Right.
Diagnosis also uses a barium swallow X-ray and EGD. Treatment is very similar to GERD: nutrition changes, meds, lifestyle adjustments, and surgery. Often that same laparoscopic Nissen fundoplication is an option. Post-op care for open surgery focuses on preventing breathing problems, pain control, careful NG tube management if needed, slowly advancing the diet, and watching for potential issues like ongoing swallowing difficulty, gas bloat, or swallowing air.
Got it. Moving further down, esophageal cancer. That sounds very serious.
It is, unfortunately. Esophageal cancer tends to grow quickly and is usually malignant. Squamous cell cancers are typically in the upper part, while adenocarcinomas are more common lower down, often linked to Barrett's esophagus from chronic GER. And because the esophagus has such a rich lymphatic network, sadly, more than half of cases have already metastasized or spread by the time they're found.
What are the big risk factors there?
Alcohol and tobacco use are major ones. Long-standing GERD, especially if it's led to Barrett's esophagus changes. Obesity is increasingly recognized as a risk factor, and also malnutrition.
And the key signs to watch for?
Dysphagia, difficulty swallowing, is usually the primary symptom. It might start subtly, just with solids, then get worse.
Okay.
Also, a sensation of a mass or fullness in the chest, a chronic cough with more secretions, regurgitation, donophagia, painful swallowing, foul breath, maybe persistent hiccups. Diagnosis involves barium swallow, esophageal ultrasound with biopsy, EGD, and PT-CT scans to check for spread.
And
Treatment includes nutritional support, often TPN, which is IV nutrition chemotherapy, radiation, sometimes photodynamic therapy, and surgery. Surgery can be palliative, just to improve symptoms like swallowing, or curative, involving removing the esophagus, which is a major operation called an esophagectomy. Pre-op care focuses on nutrition and stopping smoking. Post-op is heavy on respiratory care, wound management, and monitoring for serious leaks.
Okay. Next up, gastritis. That literally sounds like an inflamed stomach.
That's exactly what it is. Inflammation of the gastric mucosa, the
Yeah.
stomach lining, often caused by H. pylori bacteria, very common.
Right.
Or there can be a genetic link, or it can be triggered by overuse of NSAIDs like ibuprofen or naproxen. It can be acute, comes on suddenly, usually heals if the underlying cause is removed and the muscle isn't involved. Or it can be chronic.
And chronic is worse.
Yes, chronic gastritis means the stomach walls can thin over time, and you can lose the ability to produce stomach acid and intrinsic factor. Loss of intrinsic factor leads to pernicious anemia because you can't absorb vitamin B12.
Ah, okay. What are the common symptoms of gastritis?
Things like general discomfort, heartburn, nausea, vomiting, sometimes even vomiting blood, which is hematemesis cramping, and melena, those dark, tarry stools from digested blood.
How's it diagnosed and treated?
Diagnosis involves testing for H. pylori blood, breath, or stool tests, and usually an EGD to see the inflammation. Prevention is key. Balanced diet, avoiding known irritants like alcohol or spicy foods if they bother you, stress management, quitting smoking, seeking care if symptoms persist.
And treatment.
Treatment aims at the cause, so maybe antacids, H2 blockers, PPIs to reduce acid, antibiotics if H. pylori is present, and B12 shots or supplements if there's pernicious anemia. Surgery is rare, only really for major bleeding or complications like perforation.
Okay, now let's compare that to peptic ulcer disease, PUD. How is that different from just inflammation?
That's a really important distinction. PUD isn't just inflammation, it's an actual erosion, a sore in the lining of the stomach or the pylorus or duodenum, the first part of the small intestine, or even the esophagus. It's like a crater that can go deeper, even into the muscle layer or right through the wall.
So more than just surface irritation.
Exactly. They're categorized based on location: gastric, stomach, duodenal, first part of small intestine, or stress ulcers related to severe illness or trauma.
And what's the main cause of these ulcers? Is it still H. pylori?
H. pylori infection is a major cause, yes. The other big one is NSAID use. NSAID-induced ulcers can be tricky, often recurring. Genetics can also play a role, making some people more prone.
So knowing the causes, how do symptoms differ? I understand there are key differences between gastric and duodenal ulcers.
Yes, and this is really crucial for diagnosis. For duodenal ulcers, people often have hypersecretion, too much stomach acid. Pain typically hits 1.5 to 3 hours after eating, and here's the classic sign. Eating food often relieves the pain. It can also wake people up at night. Bleeding usually shows up as melena, dark stools. Duodenal ulcers are also more likely to perforate. Malignancy is rare.
Okay, so that's duodenal. What about gastric ulcers?
With gastric ulcers, acid secretion might be normal or even hyposecretion, less acid. Pain usually occurs sooner, maybe half an hour to an hour after meals, and rarely at night. And the key difference, eating food tends to worsen the pain.
Opposite effect.
All right. Hemorrhage or bleeding often presents as hematemesis, vomiting blood. And while malignancy is less common than in, say, stomach cancer, it's still a concern with gastric ulcers. Maybe under 10% are cancerous.
Got it. So diagnosis and treatment for PU.
Assessment involves checking for epigastric tenderness, dyspepsia, pain patterns, nausea, vomiting, maybe checking for orthostatic changes if bleeding is suspected. Diagnosis includes the physical exam, monitoring hemoglobin and hematocrit, HH, for blood loss, H. pylori testing, stool tests for blood, and the gold standard is usually an EGD to see the ulcer directly and maybe biopsy it.
And treatment.
Treatment focuses on the cause. Antibiotics if H. pylori is found, PPIs or H2 blockers to reduce acid, maybe prostaglandin analogs to protect the lining, especially if NSAIDs are the cause. Lifestyle changes are vital. Avoid alcohol, quit smoking, dietary adjustments. Surgery is an option for complications or ulcers that don't heal.
One of the most serious complications we need to worry about with PUD.
The big three are hemorrhage, perforation, and obstruction. Hemorrhage means significant bleeding that's an emergency. Needs EGD, fast, close monitoring, NG tube lavage, maybe labs, IV fluids, possibly blood.
Okay.
Perforation is when the ulcer eats right through the wall. That's also an emergency. Sudden, sharp pain, rigid abdomen, needs immediate surgery, fluids, electrolytes, blood.
Wow.
And pyloric obstruction is a blockage at the stomach outlet caused by swelling or scarring from the ulcer. Leads to feeling full, bloated, nausea, vomiting undigested food. Managed with an NG tube to decompress the stomach and IV fluids.
Okay, serious stuff.
Okay.
Lastly, for the upper GI, gastric cancer. What should we know here?
Gastric cancer is usually an adenocarcinoma, starting in the stomach lining glands. Often, it's quite advanced when detected because early symptoms are vague. It can spread directly through the stomach wall and into the lymph system. Certain conditions like atrophic gastritis or intestinal metaplasia are considered precancerous.
Are there specific groups or causes linked to it?
It's more common in males. Highest rates are in places like Eastern Asia, Eastern Europe, South America. Average age is around 70. Causes include H. pylori infection, pernicious anemia, certain polyps, lack of stomach acid, achlorhydria, diet, genetics, and chronic gastritis.
And the signs? Still vague.
Often, yes, initially.
Yeah.
Indigestion, discomfort, feeling full quickly, maybe epigastric or back pain, nausea, vomiting, unexplained weight loss. Later, signs of metastasis might appear. Diagnosis relies on EGD with biopsy and scans like PET-CT, MRI to stage it.
And treatment? Surgery seems likely.
Surgery is the preferred method if possible, removing part or all of the stomach, gastrectomy. Sometimes it's palliative, just to relieve symptoms. Chemo and radiation are also used. Post-op care involves managing pain, dressings, NG tube if present, preventing pneumonia, monitoring for infection, and ensuring patient safety for discharge.
Okay, let's shift gears now, moving into the lower GI tract and some broader issues. Something often linked to bariatric surgery is dumping syndrome. What's that about?
Right. Dumping syndrome happens when food, particularly sugary or high-carb food, moves too quickly from the stomach into the small intestine. There are two types. Early dumping, maybe 15-30 minutes after eating.
Pretty quick.
Yeah. And late dumping, which is more like 1.5 to 3 hours later. Late dumping is interesting. It's caused by a big insulin spike in response to the rapid sugar absorption, which then causes blood sugar to drop too low.
Oof. What does that actually feel like?
Symptoms can include dizziness, tachycardia, fast heart rate, diaphoresis, sweating, confusion, weakness, feeling really full in the upper abdomen, and cramping. It's usually self-limiting, thankfully, meaning it passes.
So how do people manage or prevent it?
It's almost entirely about dietary changes. The advice is usually to increase fat and protein, eat small, frequent meals, and here's a key tip. Lie down for a bit after meals to slow down stomach emptying.
Lie down. Okay.
Yeah, it decreases peristalsis. Also, wait about an hour after meals before drinking fluids. And crucially, no fluids with meals, and avoid high-carb things like bread, potatoes, sugary drinks that trigger it.
That makes sense. And this connects naturally to severe obesity, which has huge GI implications.
Huge. Severe obesity, defined as over 100% above ideal body weight or a BMI over 40, affects about 10% of Americans. And it's sobering. It's the second leading cause of preventable death, right after smoking.
That's staggering. What are the associated health risks beyond just the weight?
Oh, the list is long and serious. Diabetes, coronary artery disease, peripheral artery disease, stroke, hypertension, high lipids, gallbladder issues, metabolic syndrome, osteoarthritis, depression, incontinence, gout, back pain, sleep apnea, and it even impacts wound healing.
Wow.
Causes are complex, high-fat carb cholesterol diets, inactivity, some medications, but also significant familial and genetic factors play a role.
So how is severe obesity managed?
It starts with a full assessment history, physical, psychosocial. Medical management involves supervised weight loss plans with doctors and nutritionists, exercise programs, behavioral modification therapy, and treating related depression.
Are there medications?
Yes, pharmacological options include things like phentermine, an appetite suppressant, or enosistat, blocks fat digestion, liraglutide, naltrexone bupropion, and the newer class including semaglutide tirzepatide.
And when those aren't enough, surgery comes into play.
Right. Bariatric surgery is considered after non-surgical methods haven't worked, mainly to improve those serious comorbid conditions. There are generally two types. Bypass procedures, like Roux-en-Y gastric bypass, which alter the digestive route and tend to lead to more long-term weight loss.
Okay.
And restriction procedures, like the vertical sleeve gastrectomy, removing most of the stomach, or gastric banding, placing an adjustable band around the top part of the stomach.
What's special about post-op care after bariatric surgery? It sounds quite specific.
It is. Special considerations include using an abdominal binder for support, careful patient positioning, continuous oxygen saturation monitoring, compression devices or heparin to prevent blood clots, DVTs, very diligent skin assessment, using absorbent padding between skin folds and getting the urinary catheter out quickly, usually within 24 hours.
Activity is encouraged.
Yes, getting patients up and walking as soon as possible is key. They also monitor abdominal girth, start with 6 very small feedings daily to prevent dehydration, and of course watch closely for any signs of that dumping syndrome we discussed.
Got it. Let's switch to a really common functional disorder, irritable bowel syndrome, IBS. So many people deal with this.
It's incredibly common, yes. Probably the most common digestive disorder overall. It's characterized by chronic diarrhea, constipation, abdominal pain, and bloating, often alternating patterns. It's called functional because there's no visible structural damage or disease. It's more about how the gut works, impaired motor function, or sensory hypersensitivity. Spastic colon, nervous colon, those are older terms for it.
What are the classic signs, and how is it typically managed?
Key signs are that alteration in bowel pattern, pain, often lower left abdomen, bloating, distension, sometimes visible mucus in the stool. Treatment really focuses on dietary changes, identifying and avoiding triggers like caffeine, maybe eggs or wheat for some people. Increasing fiber intake substantially, like 30-40 grams a day, is often recommended.
And stress.
Stress reduction is huge. IBS is very sensitive to stress. Medications can help manage symptoms. Antidepressants sometimes, antidiarrheals like Imodium, bulk agents like Metamucil, and probiotics are increasingly used to try and balance gut flora.
Okay, moving to a more serious condition. Colorectal cancer. What are the risk factors here?
Colorectal cancer affects the colon or rectum. Most are adenocarcinomas starting in the lining, and they can metastasize. Risk factors include increasing age, a personal or strong family history, lifestyle factors like diet high in processed foods, red meats, lack of exercise, smoking, obesity, and certain underlying conditions like inflammatory bowel disease.
What are the screening guidelines? Early detection is so key.
Absolutely. For average risk folks, screening now typically starts at age 45. Options include fecal occult blood tests or FIT tests annually, stool DNA tests every few years, flexible sigmoidoscopy every 5, CT colonography every 5, or the gold standard, colonoscopy every 10 years.
And higher risk.
Higher risk individuals, strong family history, certain genetic syndromes, personal history of polyps or IBD need to start screening earlier and usually more often. That's a discussion to have with your doctor.
Definitely. What are the signs of colorectal cancer people should watch out for?
Key signs include a persistent change in bowel habits like new onset constipation or diarrhea that doesn't go away, blood in the stool bright red or dark, unexplained anemia, weight loss you weren't trying for, fatigue, a feeling of fullness like you haven't completely emptied your bowels, sometimes vomiting.
And diagnosis and treatment.
Diagnosis often involves colonoscopy to visualize and biopsy suspicious areas. Blood tests check H&H for anemia and a tumor marker called CEA, stool studies. Sometimes imaging like barium enema, sigmoidoscopy, CT, or MRI. Treatment usually involves surgery, often combined with chemotherapy and/or radiation, depending on the stage. And there are significant psychosocial aspects to manage too.
What's involved in the care for someone undergoing treatment, especially surgery?
Pre-op care includes reinforcing explanations, maybe marking a potential ostomy site. Bowel prep used to be standard. Now it's a bit more controversial, depends on the surgeon. Antibiotics before incision are standard. 5E access, addressing patient and family anxieties.
And post-op.
Post-op often involves managing an NG tube initially, IV pain control, very careful diet progression, starting with liquids, managing a colostomy if one was created, wound care, and extensive patient education before they go home. And speaking of colostomies, that's a surgical opening rerouting the colon. Where it's placed affects the stool consistency. Ascending colostomies, right side, mean liquid stool. Transverse, often temporary, are for blockages. Descending left side produce more formed stool, and sigmoid, lowest part, even more so.
Okay.
Colostomy care is a whole process. Teaching about normal stoma appearance, signs of problems, measuring the stoma, choosing and caring for the appliance pouching system, skin protection, diet tips for gas and odor, helping patients resume normal activities, and critically addressing body image and sexual function concerns.
Very important. Okay, lastly, let's look at intestinal obstruction. How does that happen?
An intestinal obstruction can be mechanical, a physical blockage. Think tumors, scar tissue from old surgeries, adhesions are very common, narrowed areas called strictures, hernias, impacted stool, twisting of the bowel, volvulus or telescoping intussusception, or it can be non-mechanical, also called paralytic ileus. Here, there's no physical block, but peristalsis, the muscle movement of the bowel, slows down or stops. This often happens after abdominal surgery or due to inflammation, electrolyte problems, or reduced blood flow.
And the signs of a blockage, do they differ based on small versus large bowel?
Yes, they do, and it helps pinpoint the location. Small bowel obstruction typically causes abdominal pain, distension higher up, nausea, often projectile vomiting. Because you lose fluids and electrolytes quickly, imbalances are severe, often leading to metabolic alkalosis.
Right.
Large bowel obstruction tends to cause lower abdominal cramps, distension lower down, maybe minimal or no vomiting initially. Fluid electrolyte issues are usually milder, sometimes metabolic acidosis. Both can cause obstipation, inability to pass stool or gas. Large bowel might have ribbon-like stools if partially blocked.
A key difference.
Yeah, generally the higher the obstruction, the quicker and more dramatic the symptoms. Vomit might even smell fecal if the blockage is lower down. Bowel sounds might initially be hyperactive, high-pitched as the bowel tries to push past, but then they can become silent, which is a worrying sign.
How is it diagnosed and treated?
Diagnosis usually involves X-rays or CT scans. Labs might show high white blood cells if there's strangulation, signs of dehydration, high H&H, BUN, creatinine, and low electrolytes. Sometimes a scope test might be used.
And treatment, non-surgical first.
Often, yes, if it's not a complete blockage or strangulated, that means NPO, nothing by mouth, an NG tube to suction out contents and decompress the bowel, good oral care, IV fluids, maybe TPN for nutrition, sometimes enemas depending on the cause, position changes, monitoring vitals closely, sometimes meds to stimulate motility.
And if that doesn't work?
Then surgery is needed. Often starts with an exploratory laparotomy to find the cause, then specific surgery to fix it, releasing adhesions, removing a tumor, repairing a hernia, etc. Post-op, the NG tube stays until bowel function returns, then a slow progression back to a regular diet, starting with clear liquids, watching carefully for nausea or vomiting.
Wow. Okay, we have really covered a lot of ground today. A true deep dive into the complexities of GI function and what happens when it goes awry. From that incredibly detailed patient history all the way to managing recovery from major surgery, it's so clear how vital this system is.
It really is. And understanding these details, even just some of them, can, I think, profoundly change how we view symptoms, how we interact with healthcare, and just appreciate the resilience of our own bodies. Hopefully this sparks some, new perspectives for you listening.
So after all that, what really stands out to you? Maybe it's that connection between something seemingly unrelated, like a cough and GERD, or the psychosocial impact of these conditions, the specifics of managing dumping syndrome.
Yeah, or perhaps how these insights might shift your perspective on your own digestive health. Maybe thinking differently about screening for things like oral or colorectal cancer. Knowing more really is empowering, isn't it?
It absolutely is. Well, that's it for this deep dive. We hope you feel more informed, more equipped with this knowledge. Until next time, keep digging deeper.